Hello, everybody. Hope you're doing well. Welcome to another Fix Your Gut live stream. I'm your host, John Brisson. Today, we're going to read from a multitude of studies, different inserts from these studies, and I'm going to discuss why here at Fix Your Gut, why I, or even my partner at Fix Your Gut, Jason Huber, why we would never take proton pump inhibitors. And there are many side effects associated with the use of proton pump inhibitors. There's many nutrient deficiencies that proton pump inhibitors cause, and we're going to discuss some of those reading studies. We're going to show conflicting results in studies and why that may be. But ultimately, it does appear that proton pump inhibitors decrease protein absorption because stomach acid is required for proper protein digestion and assimilation by the human body, which proton pump inhibitors inhibit stomach acid production. And there's also magnesium associated deficiencies in people who take proton pump inhibitors, B12 associated deficiencies in people who take proton pump inhibitors, and iron associated deficiencies in people who take proton pump inhibitors. Among the side effects that proton pump inhibitors can cause too as well, which can harm mitochondrial health. It may increase the formation of amyloid plaques, and we'll get to those discussions. But yes, proton pump inhibitors are not good medications to take. And in most times, they just treat the symptoms. They reduce your stomach acid, but not really tackle what is the main cause of having increased stomach acid or increased GERD or heartburn incidences, which are like dysbiosis in your stomach, having more bacteria or yeast in your stomach that should be there, greater colonies, because the bacterial or yeast load within one's stomach is lower compared to many other parts of the body, because the stomach tends to have a lower pH and be more acidic. So only certain bacteria that are able to survive in a low pH environment, in an acidic environment, are able to live in the stomach. So bacteria to survive, dysbiotic bacteria usually have to produce an enzyme called urease, which converts urea, which is normally produced in the stomach through natural digestion, into ammonia. And ammonia has a very high pH, so it brings the level of the stomach's pH up, so that bacteria can survive. And once they're able to survive in there, like H. pylori, for example, they start fermenting food. Stomach. The pyloric sphincter, which is a sphincter that connects the stomach to the duodenum, does not open and allow food to enter the duodenum unless the pH of the stomach reaches around 1 to 2. And the body has realized that adequate digestion has occurred in the stomach for the food to continue to move along, which is timed by the vagus nerve and a series of events called the migrating motor complex, which is both events and the structures within the human body that deal with adequate digestion. So when you have more bacteria in your stomach that ferment protein, because your stomach, more food stays in your stomach because of delayed gastric emptying, or you eat a diet that's very high in sugar that doesn't need to be, it doesn't need a lot of time for these bacteria to ferment. They produce a lot of gas, so that moves your stomach upwards. It puts pressure on the lower esophageal sphincter or weakens it. It kind of has like a volcano effect with the stomach contents pushing it upwards. And doing so, people get heartburn and bioreflux if the pyloric sphincter is weakened and it stays open, or silent reflux through pepsin, going up and staying in the esophagus and the throat and the nasal passages and the eustachian tubes and the lungs. Kind of like vapors rising up carrying pepsin, which is a protein in your stomach that helps is an enzyme in your stomach that helps digest protein, and it can digest your tissues if acid comes in contact with it. Pepsin's main It's the chief digestive enzyme that the stomach produces, and it breaks down proteins into polypeptides within your stomach. So proton pump inhibitors can increase, lead to dysbiotic flora by inhibiting stomach acid, which increases fermentation in the stomach, which increases gas and bloating, which moves the stomach upwards and weakens the LES and causes you to reflux more. So proton pump inhibitors may shortly inhibit bacteria because they have antibacterial effects, and they may reduce, the amount of stomach acid as you're refluxing, but usually it's just treating the symptom. It's not treating the cause, which in most cases is dysbiosis, unless a person has many gastrin-secreting tumors in their stomach, which is a condition called Zollinger-Ellison syndrome, where their stomach does produce too much acid, or if a person has histamine intolerance and their stomach's producing too much histamine. Usually you see that in people who are under methylators, and that can lead to reflux as well. But generally, again, you need that pressure. You need some sort of pressure to move those stomach contents upwards. I mean, that's how the laws of physics. So, all right, but let's begin. Proton pump inhibitor associated hypomagnesia, a retrospective control study. So here was them, studying back in 2016 and even sooner, that proton pump inhibitors may be linked to low magnesium levels, which is hypomagnesemia. In the United States, proton pump inhibitors are one of the best-selling drug classes. More than $9 billion were spent on PPIs in 2012. The medications available both by prescription and over-the-counter OTC are used to treat a variety of gastrointestinal conditions, including heartburn, gastroesophageal reflux disease, which is GERD, and peptic ulcer disease. Proton pump inhibitors are generally recognized as safe and effective. In 2011, however, the FDA reviewed a diverse event reporting system, reports, medical literature, and periodic safety updates. An issue a safety communication outlining the risk for hypomagnesemia with prolonged PPI use. The FDA focused on 53 cases, 30 adverse event reaction support cases, 15 in the literature, and 8 reported being both through errors and in the literature. The majority involved PPI use that continued for 1 year or longer, but in some cases hypomagnesia developed in over 3 months. So we know that the FDA had been investigating it since 2011. All right, so there's a study in 2016 looking back and seeing study results identify association with PPI use and hypomagnesia in the Veterans Administration patient population of older men. More studies needed to be conducted with non-VA patient populations to further access incidence of PPI associated with hypomagnesia. So here we have a conflicting study, however. Proton pump inhibitor use for 12 months is not associated with changes in serum magnesium levels of prospective open-label comparative study. Well, serum magnesium only represents about 1% of your body's total magnesium. Most of the magnesium in your body is stored in your bones and your muscles. And the serum magnesium, the body does whatever it possibly can to keep that level normal, because that's the level of your that's in your blood serum that's being transported in the body for acute purposes. It doesn't reflect how much magnesium is actually stored in your body, and your body does whatever it can. It will leach out of those magnesium storages to keep that serum level normal, because magnesium is crucial for many enzymatic reactions in the body, as well as its most important function as an electrolyte for proper electrical conductivity of the heart muscle. And so, people with low magnesium levels, they end up getting a heart arrhythmia because, all of the electrolytes are important for the electrical conductivity of the heart. Sodium, potassium, magnesium, calcium, and phosphorus. And they're all flammable as well. I mean, that's where we get, electrolyte. So they're testing serum. Okay, so they tested 250 patients to try to determine if they had lower magnesium levels or not. And so stable serum magnesium levels were demonstrated after 12 months, and no association between PPI use and risk of hypomagnesia was shown in the general population. Significant reductions of serum total calcium levels were demonstrated among PPI users. So interesting. This also shows a calcium deficiency too in people when you take your proton pump inhibitors. Further research is required before recommending any serum calcium and PTH monitoring in patients initiated on long-term PPI therapy. So they measured serum total calcium, which the body tends to be more calcium in the blood than there's magnesium. So you would be able to determine a calcium deficiency quicker through serum blood tests than you would magnesium tests. But here, we have the FDA, releasing the safety announcement back in 2011 about proton pump inhibitors may be associated with low magnesium. So here we have a meta-analysis that was done after the last serum study. All right, now this is the study where it's a meta-analysis, meaning they take multiple studies, okay, and since they take multiple studies, they're able to hopefully look at the evidence presented and go through it and say, okay, well, this study is flawed, this study is not flawed. And so what do all these collections of studies say? That's what a meta-analysis. What are their conclusions? There's enough evidence to show that proton pump inhibitors are associated with low magnesia or hypomagnesemia. All right? So let's read some of the study. Proton pump inhibitors are widely used for the treatment of gastroesophageal reflux disease, peptic ulcer disease, and conditions associated with increased gastric acid secretion, and for prevention of gastric ulcers in patients require prolonged use of non-steroidal anti-inflammatory drugs or corticosteroids. Although the recommended treatment duration is 48 weeks for acute gastric and duodenal ulcers, the U.S. Food and Drug Administration advises that not greater than 3 2-week treatment courses per year should be prescribed. Wow, there's people that take it on a daily basis. The FDA even is against that. High dose and prolonged use of greater than 8 weeks of PPIs have been linked to increased risk of Clostridium difficile infection, hospital-acquired pneumonia, bone loss fractures, and mortality. In 2006, an association between the use of PPIs and hypomagnesia was first described in medical literature, which is followed by several additional reports. In 2011, the FDA issued a drug safety communication stating the low magnesium levels could be associated with long-term use of PPI. So it took give or take 5 years. People in the medical literature had been discussing it since 2006. It took about 5 years for the FDA to get off their butt and actually release a warning that there might be an issue with proton pump inhibitors and lowering of magnesium. The safety communication was based on a review of 38 cases from the adverse event reporting system and 23 published case reports. We read that earlier. While the information was added to the warnings and precaution sections of labels for all PPIs, this decision by the FDA was not based on large observational or confirmatory studies. Yeah, but how many people, including myself, who've taken PPIs many years ago, and the doctor doesn't even tell you, hey, you might want to take a magnesium supplement, which isn't going to harm you in the long run. Most people are deficient in magnesium anyway, about 80%. As long as your kidneys are healthy, you'll urinate excess magnesium, or it'll cause you to have diarrhea because it's an osmotic laxative. So if you take magnesium and you have diarrhea, you need to cut back your dosage, or take a better absorbed form of magnesium, like magnesium glycinate, for example. Instead of magnesium oxide, which is very cheap. The glycine amino acid that's chelated to magnesium seems to slow down its digestion and improve its absorption, but magnesium oxide, on the other hand, is not absorbed in large quantities by the body. It tends to cause an osmotic laxative effect, but I digress there. But no, they don't tell you. They don't say, hey, some gastroenterologists and doctors will tell you that PPIs can lead to a decrease in B12, and they'll check your B12. But magnesium, and they're not even, most of the time they're going to check serum magnesium. They're not even going to check magnesium RBC, which is the magnesium amounts in your red blood cell. Though not 100% accurate, it's way better than serum. You're going to get a more accurate count of how much magnesium the body is storage by testing red blood cell or doing EXA test or a white blood cell magnesium test than you will serum. So it's a problem, magnesium is crucial for functioning of the nervous system, for cardiovascular health, for brain health, for mitochondrial health, and many people on proton pump inhibitors, because they develop hypomagnesemia that can lead to charley horses and muscle cramps and cognitive function decline and brain fog and heart arrhythmias and high blood pressure. which high blood pressure can lead over time can lead to, and inflammation in the blood vessels can lead to strokes and heart disease. So this is an issue. While this information was added to the warnings and precaution sections of the labels for all PPIs, a decision by the FDA. Okay, I read that. PPIs may cause hypomagnesia by decreasing intestinal magnesium absorption, resulting in decreased urinary magnesium excretion. Intestinal absorption of magnesium occurs through a passive and active transport mechanism involving two proteins located on the apical membrane of enterocytes. The transient receptor potential melastatin TRPM6 and TRPM7. It would not be as well absorbed, Nick. You're right about taking magnesium supplements while on proton pump inhibitors, but it's better than not taking any at all. So you might have to take a higher dosage, or you might have to soak in Epsom salt baths. Now, at one time, I did recommend the use of transdermal sodium magnesium chloride sprays, but studies have shown they don't really absorb because your skin barrier has a single collar epithelial cells, very much like your gut barrier, and that most of the time the magnesium that you spray on your body kind of just sits there and evaporates into the atmosphere, and you're kind of left with like a mineral paste on your epidermis that can itch. Where if you actually soak in a Epsom salt bath, you would absorb more of the magnesium, because the reason why your skin gets soggy is because those skin junctions break down, allowing more of the magnesium to be absorbed. So if you were going to do transdermal magnesium, you will want to do it through Epsom salt baths. But yes, taking magnesium to overcome a deficiency of the PPI, and again, I'd argue, why are you taking the proton pump inhibitor in the first place? You need to find some way to get off of it. Work with your healthcare professional to get off of proton pump inhibitor. I am not a healthcare professional, but I am someone who's very knowledgeable about the digestive system and about nutrients as well. But I would talk to your healthcare professional, your doctor, your nurse practitioner, physician's assistant, whomever, about trying to address the real problems that are leading you to having to take a proton pump inhibitor. Or pick up a copy of Fix Your Gut, or reach out to me for coaching. I'll do my best to get you off the medications and fix any issues that they may be causing. These proteins have a high affinity for magnesium absorption and play a role in maintenance of magnesium balance during periods of sparse dietary magnesium intake. TRPM activity is regulated by the intraluminal acid-base status, whereby an acid milieu increases its activity. Proton pump inhibitors decrease the activity of TRPM6, resulting in a decrease in intestinal absorption of magnesium and hypomagnesia. Previous observational studies have demonstrated variable associations between PPI use and hypomagnesia. Through previously published meta-analysis of observational studies have concluded that there might be an association between PPI use and hypomagnesemia. However, some of these reports did not conduct adequate adjustment for confounding factors. To provide an update on this topic, we provided a meta-analysis of all observational studies that examined the question and explored whether there was association between PPI dose or treatment duration and the development of hypomagnesia. So they combined all the studies, they excluded biases. So let's leave the conclusion. In the percent systematic review and meta-analysis of observational studies, we summarize the existing literature on the association between PPI use and development of hypomagnesemia. Table 6 illustrates the summary findings from 4 meta-analysis and the association between the use of PPIs and hypomagnesemia. There are 3 previous meta-analyses on this topic, 2 that included 9 studies and 1 that included 14 studies. Some of these reports did not properly account for factors that may confound this association. In addition, in previous published meta-analysis, while subgroup analysis were conducted according to clinical settings, ambulatory versus hospital settings, serum magnesium cutoff values exactly, and study design, none explored the potential association between the dose of PPIs and duration of use and development of hypomagnesemia. We found that low-dose PPI use was associated with increased odds for hypomagnesia relative to non-PPI use, and that high-dose PPI use was also associated with increased odds of hypomagnesemia relative to low-dose PPI use. Of note, in recently published prospective open-label comparative study, long-term 12-month duration PPI use was not associated with changes in serum magnesium levels. However, serum calcium levels declined over time. I've discussed why that may be the case. The mechanism of PPI-induced hypomagnesemia is unknown. Current evidence shows that urinary magnesium excretion is not elevated among PPI users. Ruling out urinary magnesium losses as a potential mechanism. There's evidence to support intestinal loss or malabsorption of magnesium, which will lead to you having diarrhea and evacuating the magnesium through your bowels. Furthermore, variant alleles of TRPM6, TRPM7 genes are associated with subtle intestinal malabsorption and persistent urinary loss of magnesium, which may be further aggravated by the use of PPIs in susceptible persons. So if you have polymorphisms in the genes TRPM6 and TRPM7, you might need to take more magnesium. You're more prone to not absorbing magnesium as well. Our systematic review has several strengths. To the best of our knowledge, this is the first systematic review and meta-analysis of observational studies that explores the association between high-dose PPI relative to low-dose and development of hypomagnesemia. We included reports that performed multivariable analysis to account for potential confounders of these associations. However, there are important limitations that should be noted. First, our synthesis of the evidence was limited to observational studies, and in the absence of randomized controlled trials, the cause and effect relation between PPI use and hypomagnesemia remains speculative. Second, there was significant heterogeneity among the individual studies in terms of clinical settings, study design, indication, and dose of PPIs, types of PPIs, and duration of use between the development of hypomagnesemia. Subgroup analysis linking to the PPI dose to hypomagnesemia should be interpreted with caution due to limited evidence. Furthermore, the definition of hypomagnesemia also varies significantly among individual reports. Our analysis is also inconclusive regarding the potential link between the use of PPIs and adverse cardiovascular outcomes, including cardiac arrhythmias mediated by hypomagnesemia. In conclusion, our systemic review indicates that patients taking PPIs, particularly high-dose proton pump inhibitors, are at increased risk of developing hypomagnesemia despite significant heterogeneity among the individual studies. Hence, we recommend that serum magnesium be monitored. I would say serum and magnesium RBC levels be monitored. In patients prescribed a PPI long-term, particularly those prescribed high-dose PPIs, additional post-marketing population-based surveillance studies are needed to further elucidate whether long-term use of PPIs is associated with adverse cardiovascular events, namely hypomagnesemia-induced cardiac arrhythmias. And no disclosure of funding. Proton pump inhibitors intake and iron and vitamin B12 status, a prospective comparative study with a follow-up of 12 months. So here we have a study where they're like, yeah, B12 deficiency might not occur in proton pump inhibitors. We'll read the discussion, and then we'll see follow-up studies to this study that show that, well, it's very likely by inhibiting intrinsic factor through a reduction of proper stomach acid. It does lead to a B12 deficiency in people who take proton pump inhibitors. The results of the current study indicate a significant association between PPI use for 12 months and a reduction in body iron stores in vitamin B12 levels and a higher prevalence of HHCY among PPI users. Our findings suggest that prolonged PPI therapy affects iron and vitamin B12 status. Nevertheless, a subsequent diagnosis of hyperferemia and vitamin B12 deficiency at the end of the study was established in only 3.8 and 2.9 of the subjects, respectively, without significant differences between PPI users and non-users. Other studies that noted the association between clinical conditions associated with achlorhydria or hypochlorhydria, which is low stomach acid or lack of stomach acid, and diminished intestinal iron absorption raised interest about the potential effects of prolonged PPI therapies on iron status. Years later, through mutations on proton pumps on rats, confirmed the necessity of a gastric proton pump for iron absorption. Nevertheless, the number of studies that have specifically investigated the association between prolonged PPI use and iron status is relatively small. One of the first studies to suggest such an association is a case report of 2 anemic patients, in which no response to oral substituted therapy with iron was noted when the patients continued to take proton pump inhibitors, while their iron status improved after PPI withdrawal. This made the authors to attribute the non-responsiveness to iron therapy to PPIs. Another study on patients with hereditary hemochromatosis that require frequent phlebotomies, administration of PPIs for 7 days, resulting in a significant reduction in the amount of blood removed per annum to maintain adequate iron blood stores, ferritin levels of 50 UGL. A retrospective cohort study of Saransky et al. On adult outpatients who have been on PPI therapy for at least 1 year demonstrated a significant reduction in hematologic indices compared to baseline values. Similarly, in a research study of Shikata et al., provide the PPI use was associated with anemia in cardiovascular outpatients, thus reporting a frequency of anemia among PPI users compared to non-users. 51% versus 19% with a p-value less than 0.001. The findings from the study indicate significant changes in iron body stores, serum ferritin levels among PPIs and specific PPI subgroups between the two time points. While no significant changes in serum iron levels except for borderline significance with PPI users as a single entity, and speak for pre-latent iron deficiency, that's actually the initial phase of pathogenesis of iron deficiency anemia. So I would recommend people with anemia or that is due to a lack of iron and not necessarily due to iron metabolization and utilization issues. You can look into the work of Morley Robbins' root cause protocol for more information on that. I wouldn't recommend that someone supplements with an iron supplement. Iron supplements can cause inflammation in the gastrointestinal tract. They can cause constipation unless you use iron bisglycinate, which is iron chelated to glycine, which slows its absorption and leads less to constipation. Bacteria love to eat iron, so ingesting iron, especially if you have dysbiosis, can worsen the dysbiosis. They like to bacteria like to ingest iron. They need iron. Many bacteria need iron to continue living and multiplying and forming new colonies. They need it for survival. And iron can be reactive to the tissues of your mucosal barrier of your intestinal tract and trigger inflammation there and worsen leaky gut. So for most, because most of the iron that we ingest is either bonded to hemoglobin or bonded to phytic acid or bonded to other transporting proteins. Especially if you're ingesting animal iron, it's going to be bonded to hemoglobin to some degree or iron transporting proteins. Where you're eating plants, most of the iron is bonded to phytic acid. And there's some free iron, and some of that you will absorb, but it's not as much as taking an iron supplement or taking an iron supplement or eating iron fortified foods, which I wouldn't recommend either, because that free iron, your body does whatever possibly can to keep iron bonded until it's needed, it's needed for normal cellular function. It's needed for hemoglobin. And the transportation of oxygen and carbon dioxide. It's needed for proper mitochondrial function and electron transport chain. But if iron is free and becomes exposed to oxygen, well, it can cause mitochondrial stress and damage. So you don't want to ingest a lot of free, unbounded iron. Now, granted, the iron in the supplements are generally bonded to something, but they still tend to trigger reactions that ingesting iron, like in the form of meat, doesn't. At least from a cellular level in the mucosa of your digestive tract, mucosal barrier. So yeah, if you take it a PPI, you should eat meat. Granted, it's going to, PPI is going to hinder your protein ingestion, so you're going to have to take some sort of, digestive enzyme that contains protease to help with that. You shouldn't be taking a proton pump inhibitor, if all possible anyway. Or you should ingest beef liver, or take pastured beef liver capsules, which have a good amount of iron in them. Okay. The findings from the study indicate significant changes in iron body stores, serum ferritin levels among PPIs and specific PPI subgroups between the two time points, while no significant changes in serum iron level except for borderline significance when PPI users as a single entity. And speak for pre-latent iron deficiency, that is actually the initial phase of the pathogenesis of iron deficiency anemia. In recent years, there has been a growing interest in the relationship of PPI's prolonged use and vitamin B12 deficiency. However, there is still considerable uncertainty about providing monitoring recommendations. Potential mechanisms behind the increased risk of vitamin B12 deficiency in prolonged PPI users are vitamin B12 malabsorption and bacterial overgrowth in the gut. Yeah. Maricart et al. Were among the first to prove dose-dependent reduction of absorption of cyanocobalamin, which is the worst form of B12 to take. It's cyanide bonded to cobalt, the mineral cobalt. Methylcobalamin is better. If you don't know your methylation status of whether you're under methylator or over methylator, you probably should do hydroxycobalamin, which only contains a little bit of methylcobalamin. The rest of it is adenosylcobalamin, which adenosylcobalamin is a form of B12 that's used by the mitochondria. So there's different forms of B12. Adenosylcobalamin is primarily used by your mitochondria. Methylcobalamin has a methyl donor, which improves the functioning of the methylation cycle. But if you're an overmethylator, which means you have your methylation cycles are going are happening too quickly from a cellular level, you wouldn't want to add extra methyl donors and methyl groups and cause you to react more. So for most people, if you don't know the status of your methylation, if you're under methylator or over methylator, you should probably stick to hydroxycobalamin. But yes, you don't want to ever take cyanocobalamin. It gives you a little bit of cyanide, which cyanide shows no biological purpose in the human body, and it's inferiorly absorbed. So, but I digress. On short-term therapy with omeprazole for 2 weeks. Nevertheless, an increased risk for vitamin B12 deficiency due to the long-term use of PPIs was first reported by Taramani et al., a prospective study performed on patients with Zollinger-Ellison syndrome. I mentioned Zollinger-Ellison syndrome earlier. In the last few years, much more information has become available about the association between long-term use of PPIs and vitamin B12 deficiency. More recent studies of Lamb et al. And Lewis et al. Have also indicated the presence of vitamin B12 deficiencies in patients exposed to chronic proton pump inhibitor. The findings from the study lend support to previous findings in the literature with data analysis indicating significant changes in vitamin B12 levels among PPI users, specific PPI subgroups at 12 months, as well as significantly higher in study incidences of HHCY among PPI users. Nevertheless, HCY serum levels in PPI... I think that's homocysteine, which would show poor methylation. Let me see. Yes. So one way you can check to see if you're an overmethylator or undermethylator and in the methylation cycle, homocysteine is recycled to be used again. And homocysteine, having elevated homocysteine, is a marker of improper methylation being occurred because homocysteine isn't being recycled back, which is part of the methylation cycle. So homocysteine is usually recycled back into methionine, and of course that methionine salvage which is required is methyl tetrahydrofolate as a methyl donor, usually, and cobalamin, B12 related enzymes, so if homocysteine is not being recycled back into methionine, and then homocysteine is produced. Well, hold on. Okay, so homocysteine can be recycled back into methionine, but homocysteine can also be converted into cysteine. Okay, so there's two pathways there. So yeah. You want your homocysteine to either turn into cysteine or you want it to turn into methionine. You don't want it to just have high levels of homocysteine in the body. So you have I try to remember so you have methionine, which receives an adenosine group from ATP, which is catalyzed by S-adenosyl methionine synthetase, which gives SAM, which is S-adenomethionine. So you end up having S-adenomethionine, and then SAM transfers the methyl group to an acceptor molecule. And so that ends up All right, sorry about that. So, yes. So, um, the body through S-adenyl cell methionine to S-adenyl homocysteine produces homocysteine from methionine, and it can either be recycled back into methionine or converted into cysteine. And elevated homocysteine levels in the body have been linked to increased vascular inflammation from improper methylation cycles and improper mitochondrial function as well from improper methylation cycles. So there's a possibility that elevated homocysteine levels in PPI users might be from vitamin B12 deficiencies. Nevertheless, homocysteine serum levels in PPI users resulted in a slight but non-significant increase that may seem controversial at first because homocysteine reflects the functioning status of vitamin B12, but it can be explained by the fact that higher levels of homocysteine are more prevalent in lower levels of B12, and vitamin B3 deficiency was established in only 2.9% of the subjects. On the other hand, we should mention that the studies do not support our findings of association between long-term use of PPIs and vitamin B12 deficiency. The main reason for this inconsistency in findings is still not completely clear. We are completely unaware that our study may have certain limitations. The first might be the sample size that was arbitrarily chosen. Another one is inability to assess dietary intake of iron and vitamin B12. Fortunately, we're unable to measure folic acid serum levels and methylmalonic acid serum levels, which would be indication of B12 deficiency. If you're looking for a B12 deficiency, you want to check serum B12 and methylmalonic acid. Specific marker of vitamin B12 status, which may have also influenced the results. So the study's flawed, right? The study's very flawed. So here we have further studies from that one study. Here is two doctors discussing their own research into B12 deficiencies after that study. And they're discussing among patients taking PPI for at least 2 years, higher doses were associated with higher odds of B12 deficiency. See table. So again, the longer you took the PPI, the greater your dosage, the more likely to have a vitamin B12 deficiency. And then again, okay, so proton pump inhibitors cause vitamin B12 deficiency, possible iron deficiency, possible calcium deficiency, and magnesium deficiency. Okay, so that's known through the literature. Most of the studies that show otherwise, as I've shown, there are flaws within the studies. They're checking serum magnesium, for example. They're not checking methylmalonic acid for B12. There's limitations to the study sizes. There's enough if you do a meta-analysis of all the B12 studies of whether PPIs reduce B12 statuses in the human body. They do. Okay. So now we have a long-term use of proton pump inhibitors and risk of gastric cancer, a review of the current evidence. This is from 2019. Gastric cancer is the 5th commonest cancer and the 3rd leading cause of cancer-related mortality worldwide. In 2015, an estimated 1.3 million incident gastric cancer cases were diagnosed, and there were 819,000 gastric cancer-related deaths. Helicobacter pylori infection was classified by the World Health Organization as a type 1 carcinogen in 1994. But wait a minute, John, they were still treating ulcers as primarily caused by stress and not by H. pylori dysbiosis back then. But the World Health Organization somehow knew that was a type 1 carcinogen. But they didn't start treating H. pylori infections as the cause of gastric ulcers or as a cause of heartburn until the 2000s. Chronic H. pylori infection confers a more than 3-fold increased risk in gastric cancer, which accounts for 78% of all gastric cancer cases and 89% of non-cardiac cancers. H. pylori-associated gastric carcinogenesis is generally believed to start from chronic gastritis, progressing to atrophic gastritis, intestinal metaplasia, dysplasia, and ultimately cancer. Atrophic gastritis, intestinal metaplasia, and dysplasia are therefore regarded as precancerous gastric lesions. In a prospective study, patients with corpus predominant gastritis, relative risk RR 34.5, 95% confidence interval, 7.1, versus antral predominant gastritis. So that's positions of the stomach. severe gastric atrophy, and intestinal metaplasia were all at a higher risk of gastric cancer development. The magnitude of risk was confirmed in another cohort study. In this regard, eradication of H. pylori, which has been shown to reduce the gastric cancer risk by 33 to 47%, but a considerable proportion of H. pylori eradicated individuals still progress to develop gastric cancer. Because are they completely eradicating the H. pylori? They're not. They're just reducing it, the qualities of H. pylori by using anti-H. pylori therapy. Are they reducing the inflammation in the stomach and correcting the diet and correcting the problems that led to the H. pylori dysbiosis in the first place? Are a majority of these people still taking acid-reducing medications? My answer would be yeah. They're not correcting the problem. They might rid the stomach of the H. pylori, but by not reducing the inflammation in the stomach, or by not healing the damage in the stomach if possible, it leads to people still developing gastric cancer. Apart from chronic H. pylori infection, proton pump inhibitor usage is another potential risk factor for the development of gastric atrophy. With the potent acid suppression, PPIs can induce changes in the gastric environment, including hypergastrinemia and enterochromaffin cells hyperplasia. Ooh, okay. So serotonin-producing cells. Wow, there's damage to them. There's also evidence suggesting that PPIs can contribute to bacterial overgrowth in the stomach. Yeah, I've talked about that. Intuitively, PPIs worsen gastric atrophy and hence should increase the risk of gastric cancer. In a review, we will examine the latest literature to decipher the roles of PPIs in gastric cancer development, particularly in relation to H. pylori infection. So, proton pump inhibitors have become one of the most common prescribed medications worldwide since their introduction in the 1980s, and been a cornerstone for the management of upper gastrointestinal diseases, including peptic ulcer disease, H. pylori infection, dyspepsia, and gastroesophageal reflux disease. However, emergent data has shown long-term PPIs are associated with a number of side effects, including bone fractures, Clostridium difficile infection, pneumonia, myocardial infarction, and stroke. And although a causality has not been confirmed, potent acid suppression has long been a suspected risk factor of gastric cancer by worsening gastric atrophy with ensuing hypergastremia and bacterial overgrowth in the stomach. Animal studies have shown that acid suppression by omeprazole and the insurmountable histamine 2 receptor antagonist loxodine induce gastric mucosa neoplasia in rodents. However, evidence on human subjects remains controversial. Herein we summarize the postulated mechanisms underlying the carcinogenic effects on gastric cancer development. So, so they have synergistic effect with H. pylori and release the bacterial overgrowth by using a PPI, worsening of gastric atrophy, ECL cell hyperplasia, and increased production of gastrin. H. pylori typically colonizes the gastric atrium and cause of atrium-predominant gastritis is most effective subjects. Atrial mucosal inflammation, in turn, stimulates gastric secretion, maintaining a normal or high acidic environment. However, when the acid production is suppressed by proton pump inhibitors, the pattern of gastritis shifts to the corpus predominant gastritis. Okay, that's interesting. Where a resultant impairment of peritoneal cell function, a phenomenon that does not occur in H. pylori negative patients. As such, the acid suppressive effect of PPIs is further enhanced by H. pylori induced corpus gastritis. Okay. Okay, that's interesting. So, if I remember correctly, atrium is at the bottom part of the stomach, towards where that pyloric sphincter is. The fundus is at the top. Then you have the body of the stomach, which I think the body of the stomach is the corpus. I think. In a cohort study with 177 patients, atrophic gastritis only developed in H. pylori infected but not H. pylori negative patients. The long-term PPI use during the mean follow-up of 5 years. A systemic review also showed that the risk of corpus atrophy was more pronounced in H. pylori infected than H. pylori negative PPI users. Hypergastrinemia. In response to the suppression of gastric acid production by PPIs, there is a compensatory increase in gastric production as a negative feedback. Yeah, because the body's trying to overcome that because stomach acid's for proper digestion. Yeah. Production is for proper digestion. A recent systematic review by Lundell and colleagues, including 16 studies with 920 patients, showed that during long-term use of greater than 3 years of PPI use, the mean gastric levels rose to 1 in 3 times the upper limit of normal. The pro-growth effect of gastrin is expected to play a role in gastric cancer development. Hypergastrinemia drives the hyperplasia of enterochromaffin-like ECL cells in the oxynic mucosa, which occurs in 10 to 20% of patients with long-term PPI use. It has been reported the risk of ECL cell hyperplasia is higher in H. pylori infected than H. pylori negative patients. Similar results were reported in 2 randomized clinical trials on acid reflux control by either anti-reflux surgery or long-term PPI therapy. Analysis of the insulin gastric transgenic mice raised the possibility that hypergastrinemia may promote gastric cancer through the gastrin receptor and the cholecystokinin receptor 2, CCK2R, with overexpression of a mediated gastrin through the insulin-promoted upstream of human gastrin-coded sequences. These mice developed gastric intestinal metaplasia and dysplasia, and some even developed gastric corpus cancer, which is later accelerated by infection by Helicobacter phylis, or H. pylori. Another study, PPI omeprazole, led to a further progression to dysplasia in H. phylis infected INS-GAS mice. Furthermore, another study also suggested that the promotion of growth of gastric carcinomas of intestinal type may be due to the indirect effect of hypergastrinemia via stimulation of the release of signal substances, histamine, regenerated gene protein from the ECL cells. That's interesting. In line with the animal studies, clinical evidence of the case control study nested with the all-male alpha-tocopherol beta-carotene cancer prevention study of 29,133 Finnish male smokers with more than 24 years of follow-up reported the higher gastrin level 4th quartile versus 1st quartile was associated with increased risk of non-cardiac gastric cancer. Although ECL cells are generally believed to play little role in human gastric carcinoma development, ECL cell neuroendocrine tumors, NETs, and adenocarcinomas were observed in cases of pernicious anemia. So pernicious anemia is anemia that's caused by a B12 deficiency. Autoimmune gastritis with corpus atrophy, and thus low gastric acid output, which, by the way, again, there's in multiple studies, if we're going to circle back to PPI use and B12 deficiency, there are multiple studies that indicate that PPI use causes pernicious anemia. And pernicious anemia is B12 deficiency. That's what its clinical term is, of what it causes. So if you take a PPI and you have symptoms of pernicious anemia, you get out of breath walking to the mailbox, you get out of breath when exercising, you can't get enough oxygen in, you look pale, your nail cuticles, when you press down on them, it takes longer for them to fill up and return to color. All those signs are of pernicious anemia, and you need to get your B12 levels checked. You need to get your serum B12 levels checked. You need to get your methylmalonic acid levels checked, especially if you're on a proton pump inhibitor. You likely have B12 deficiency. I mean, it's all there. Early studies show that distinction between gastric NETs and adenocarcinomas may be difficult in both animals and humans, as ECL cells may lose many of their neuroendocrine characteristics during neoplastic transformation. However, some studies later suggested that a proportion of gastric adenocarcinomas, in particular the signet root subgroup of gastric carcinomas of diffuse type, include develop from the ECL cells. Improved sensitivity of immunohistochemical methods for detecting non-endocrine ECL cell makers. It was shown in one study that virtually all gastric adenocarcinomas in patients with severe hyperglycemia were malignant ECL cell non-endocrine tumors. Good God. Acid suppression of PPIs can lead to both luminal and mucosal non-H. pylori bacterial overgrowth, called dysbiosis, in the stomach that may exacerbate chronic inflammation. I've coached many people with upper gut dysbiosis that test negative for H. pylori but still have the symptoms of H. pylori dysbiosis, like silent reflux, GERD, heartburn, bowel reflux, gastritis, abdominal pain, bloating in the stomach, increased belching, ulcers, but they test negative for H. pylori. There are many bacteria that are able to colonize the stomach, like H. pylori, like Protus mirabilis, for example, or Citrobacter, that are able to colonize the stomach. And many people, they go get tested negative for H. pylori, and they're like, well, I don't have H. pylori, but they come to me and they obviously have bacterial dysbiosis in the stomach. But what do the doctors do? They don't try to correct the dysbiosis. Instead, oh, we'll put you on some proton pump inhibitors. Don't worry that it'll cause mass nutrient deficiencies. Don't worry that you might end up, or even likely to end up developing gastric cancer because we're not tackling the overall problem, which is dysbiotic flora in the stomach. Oh, don't worry about this. This will take care of your heartburn and your gastritis and your ulcers. It's sad. It's really sad that this is what it's come down to. This simultaneous infection with H. pylori and non-H. pylori bacteria is a synergistic effect. Yep, it's called a co-infection of inducing a higher level of serum cytokines, interleukin IL-1 beta and interleukin 8, increasing the risk of atrophic gastritis. Moreover, there's an increase in the number of bacteria, including non-gastric microorganisms, mainly from oral flora, that possess nitrate reductase to produce N-nitroso compounds from food nitrates, known causes of gastric carcinogens. Your saliva has more nitrates in it than it does eating foods preserved by nitrates or foods that naturally contain nitrates like celery, but I digress. Interestingly, it has been shown that gastric microbiota alternation is distinct in atrophic gastritis. PPI users showed similarly high gastric microbial diversity as healthy subjects. A relatively high gastric microbial diversity dominated by Streptococcus was observed in autoimmune gastritis, while decreased microbial abundance and diversity was induced by H. pylori infection. All right. I'm going to read the rest of this study, and then we're going to probably do a part 2 on PPIs. The part 2 is going to go more into the amyloid beta production, enhancement of PPI, and reduction of cognitive function on proton pump inhibitors, and the increase of the risk of dementia. And we're going to finish with a meta study that talks about all the issues associated with proton pump use, which might be the third stream in this series because it's just so much information to go over. But when I'm done with this series, no one should, want to take a proton pump inhibitor. I won't. The only time I would ever maybe consider it would be if I had a perforation in my stomach. But you could just use dual dosage Pepsid as an H2 antagonist, which is safer in my opinion, than having to use a proton pump inhibitor. So, the incidence of gastric cancer indeed has been gradually declining in the past 50 years, with an average estimated annual percentage decrease of 2.5 per year. This observation has therefore been used as an argument against the potential carcinogenic role of PPIs, which have been available only since 1989. However, it could be overemphasized that reduction in the prevalence of H. pylori and improvement in food processing actually contribute to this observed decline in gastric cancer incidence, hence masking the possible effect of PPIs on increasing gastric cancer incidence. As gastric cancer is a relatively rare disease which requires a long-term lag to develop, randomized clinical trials demonstrating the potential carcinogenic effects of PPIs are both resource and labor intensive. More importantly, there might be an ethical issue in randomizing patients to receive intervention to observe primarily adverse outcome. As such, the determination of the causal relationship could at best be determined by well-designed observational studies controlling for known confounding factors with minimization of biases. There are two meta-analyses between RCTs assessing precancerous gastric lesions and PPIs. Not surprisingly, no association between PPIs and gastric cancer was found, as the follow-up in these studies was relatively short. Maximum follow-up was 36 months. On the other hand, a systemic review of 3 observational studies by Tran, Dewey, and colleagues showed that proton pump inhibitors were associated with increased risk of gastric cancer. Pooled OR 1.43, 95% CI 1.23 to 1.66. Inconsistent results were, however, observed when the effects of PPIs were studied according to the duration of PPI use, less than 1 year, greater or equal to 1 year, and greater than 3 years. If only patients with PPI use less than 1 year were compared with non-PPI users, the pooled OR was 1.76 with a 95% CI 1.24 to 2.52. However, no statistically significant association was observed with for patients using PPIs greater or equal to 1 year, pooled OR 1.3195%, CI 0.79 to 2.19. That's a pretty strong confidence interval there. But the greatest risk was noted for those using PPIs for greater than 3 years, pooled OR 2.445, 95% confidence interval, 1.41 to 2.45. The authors propose that PPIs may be prescribed for a short period as part of the H. pylori eradication regimen for those using PPIs less than 1 year. And when sufficiently long enough time is allowed, PPIs and H. pylori infection act synergistically decrease the gastric cancer risk in those using PPI for greater than 3 years. On the other hand, previous reassuring studies on the long-term safety of PPIs neither had sufficient observation period nor adequate power with small sample size. Moreover, there are other limitations of previous studies. First, all except a study by Poulsen et al. Failed to adjust for H. pylori status or eradication. As such, the establishment of causal relationship between PPIs and gastric cancer is severely compromised by the most important confounding factor for gastric cancer development. Second, indication bias is possible as only the study by Garcia and colleagues took the indication of PPIs, GERD, PUD, and dyspepsia into analysis. Third, protopathic bias or reverse causality exists since the presence of pre-diagnostic cancer symptoms may warrant the prescription of PPIs. Fourth, most of the studies failed to take account the potential role of other medication in gastric cancer development, including statins, metformin, which I've discussed metformin, aspirin, non-steroidal anti-inflammatory drugs, NSAIDs, and cyclooxygenase 2 COX-2 inhibitors, which are all medications that have been associated with causing gastritis and ulcers. And metformin inhibits B12 absorption. But I digress. To address the confounding effect of H. pylori infection, we've recently carried out a territory-wide retrospective cohort study on H. pylori eradicated patients. N equals 63,397 during a median observation period of 7.6 years. Interquartile range 5.1 to 10.3 years. PPI use defined as at least weekly use was associated with increased gastric cancer risk, HR 2.4, 95% confidence interval of 1.42 to 4.20. That's a higher number on the second part, confidence interval. On the other hand, H2RAS was served as a negative control exposure, were not associated with increased risk of cancer risk. HR is 0.72, 95% confidence interval of 0.48 to 1.07. While non-PPI use is the reference group, the risk of gastric cancer by PPI use increased with increasing frequency. HR 2.3 for weekly to less than daily use, and HR 4.55 for daily use and duration, HR 5.04, 6.65, and 8.34 for greater than 1 year, greater than 2 years, and greater than 3 years, respectively. Wow, that's okay. The adjusted absolute risk difference was 4.29, more gastric cancer cases per 10,000 person years in PPI users than non-PPI users. Furthermore, another matched cohort of PPI users who had not received H. pylori therapy, N equals 142,460, was recruited for comparison. Of note, PPI users without prior H. pylori therapy had the lowest incident rates of gastric cancer, 0.8 cases per 10,000 person years. Among the three groups, non-PPI users with prior H. pylori therapy, 2.9 per 10,000 person years. PPI users with prior H. pylori therapy, 8.1 per 10,000 person years. Therefore, the presence of current or even prior H. pylori infection appears to be a more important determinant of gastric cancer risk than PPIs, and PPI-associated gastric cancers are more likely to occur in subjects with underlying H. pylori-associated gastric damage. Our study is the first to demonstrate that long-term PPI use is still associated with increased gastric cancer risk even after H. pylori eradication, with a dose and time response relationship. Several efforts of our study in minimizing the bias to determine a plausible causal relationship should be noticed. First, a large sample size and long observation time allows for the accurate estimation of the gastric cancer incidence among PPI users. Second, proteopathic bias was avoided by excluding PPI prescription in the 6 months preceding gastric cancer diagnosis. Third, indication bias was unlikely a significant issue, as a similar increase in gastric cancer risk was not observed for H2RASs, which would be, I would assume, histamine 2 receptor antagonists, which would be like Pepsid, which are less potent than PPIs in terms of acid suppression. Okay, yeah. In addition, the lowest gastric cancer risk among PPI users without prior H. pylori therapy argues against a significant indication bias. Fourth, comorbid conditions and medications which have not been adequately addressed in previous studies were included in the propensity score adjustment. Nevertheless, several limitations exist, including failure to capture some of the risk factors like lifestyle factors, family history, and histology information from the electronic healthcare database system. 4 recent studies by other groups published after our studies and findings consistent with ours. Among the 4 studies, one is a nationwide population study based from Sweden, a country with relatively low gastric cancer incidence. Examining the gastric cancer risk in PPI users and histamine 2 receptor antagonist users as compared with the Swedish background population of the same age, sex, and calendar period, 7.1 to 7.6 million adults. The standardized incident ratio of gastric cancer with PPI use was 3.3, with a 95% confidence interval between 3.25 and 3.53. Despite a sensitivity analysis to address proteopathic bias, all gastric cancer cases diagnosed within 1 year of the study commencement were excluded. The risks remain albeit attenuated. Again, histamine 2 receptor antagonist use was not a significant risk factor. 0.57%. So as you can see, there is a link, definitely a link between gastric cancer H. pylori and gastric cancer H. pylori and proton pump inhibitor and gastric cancer and PPIs use. The remaining 3 studies were from Asia, including 2 from Taiwan and 1 from Japan. The 2 Taiwanese studies were both case control studies. Controls were age and sex matched with cases in a 1-to-1 ratio. The first one, N equals 2,122, showed that PPIs were associated with increased gastric cancer risk by 2.48-fold. 95% confidence interval between 1.92 and 3.20. Among GERD patients, a higher risk was demonstrated by an increase in defined daily dose. The second study, N equals 1,298, also showed a similar result with longer duration of PPI use, conferring a higher risk as compared with non-PPI use. The Japanese study was a retrospective cohort study of 571 H. pylori eradicated patients, which addressed one important limitation of previous studies by adjusting for gastric precancerous lesions, corpus atrophy, and intestinal metaplasia. During a mean follow-up of 6.9 years, PPI use was associated with increased gastric cancer risk. Such an association was observed among patients with intestinal metaplasia, indicating PPIs potentially increased gastric cancer risk in patients with pre-existing gastric precancerous lesions. Notably, the use of PPIs was higher among patients with mild intestinal metaplasia than those with severe changes, which may be related to the small sample size from the subgroup analysis. Table 1 summarizes the characteristics and results of various observational studies. However, it is noteworthy that some important risk factors, diet, smoking, alcohol, family history of gastric cancer, were not taken into consideration in some of the observational studies. In addition, residual confounding is inherent in all observational studies. Therefore, a causal relationship between PPIs and gastric cancers can still not be firmly established. Nevertheless, fulfillment of the Bradford-Hill criteria may help to strengthen the possible causal relationship. Animal studies show that longer-acting PPIs can produce a higher risk of gastric tumors due to greater systemic exposure and higher concentration time, leading to more gastric stimulation. However, meta-analysis concludes that different PPIs can be used interchangeably based on potency, as reflected by the percentage time of pH greater than 4 over a 24-hour period. Omeprazole 30 milligrams is equivalent to lansoprazole 30 milligrams, equivalent to esomeprazole 20 milligrams, and rabeprazole 20 milligrams. So they talk about possible chemo-preventive agents to reduce proton pump inhibitor-associated gastric cancer risk. They talk about aspirin, metformin, and statins reducing gastric cancer risk among PPI users. However, there also studies the link that those drugs worsen cancer too. They have an anti-inflammatory effect and worsen the microbiome as well that can lead to cancer. So it's a double-edged sword, in my opinion. Recommendations on proton pump use in clinical practice. Despite the potential harmful effects of PPI, they are so far the most effective therapy for peptic ulcer disease, GERD, and preventing aspirin and NSAID-related upper gastrointestinal bleeding. I disagree with that statement. Indeed, the rational use of PPI should be promoted to minimize any potential side effects associated with long-term use rather than irrational avoidance. I disagree with that. Physicians, because it's not irrational avoidance, it's rational avoidance. There's so many issues associated with. I mean, for aspirin and NSAID-related upper gastrointestinal bleeding, you have them take the medications with food. You have them take nitrous oxide promoting foods like eat beets frequently or celery, or have them take L-arginine. All those may help protect, or you have them coat their stomach before they take the drugs, like have them take DGL or slippery elm, as long as they don't have oxalate metabolism issues for slippery elm, which is high in oxalates, or zinc carnosine. I mean, there's many different ways. Physicians should consider the lowest effective dose of PPIs with a finite treatment period. I agree with that. If you're going to use PPIs, that's what you should do. Particularly for non-erosive GERD and non-ulcer dyspepsia, a step-down approach to less than potent acid-suppressant agents, such as histamine 2 receptor antagonists, should be considered in appropriate settings. Yeah, I agree with that too. However, certain clinical conditions may mandate long-term PPI use. For instance, individuals who are at high risk of aspirin, NSA-related UGIB should be giving long-term PPIs. I disagree with that. Barrett's esophagus is another condition in which long-term use of PPIs is recommended. I also disagree with that. The cause of Barrett's esophagus is bile reflux, not acid reflux. The use of PPIs are usually useless. Long-term PPI use is necessary. It's advisable to have H. pylori tested and eradicated if present, so to prevent development of corpus atrophy, hence reducing gastric cancer risks. That is true. All right, everybody, we will pick up this stream at another time. This will be a series of streams on why I would not take proton pump inhibitors. Hope you found this informative. Nick's last question was, how long would it take for the stomach to recover for about 6 years of PPI use? Don't really know. You just want to improve your digestion. So you want to increase stomach acid production or lower your stomach pH. You want to make sure your stomach, that you're ingesting adequate amounts of healthy salt in your diet, like using real salt from Utah. The chloride can be used to produce stomach acid. You want to maybe take zinc carnosine to if you can tolerate it. Of course, run all of these suggestions by your healthcare professional. I am not a healthcare professional, however, I am knowledgeable about how the gastrointestinal system works. You might want to take some zinc carnosine. Maybe 2 capsules with breakfast and 2 capsules with dinner, and finish a bottle to improve the cellular function and health of your stomach cells. You just want to reduce inflammation. Make sure your diet's very high in clean sources of omega-3 fatty acids like wild-caught salmon, sardines, flounder, cod, low mercury sources of omega-3 fatty acids. You want to make sure that you don't have, the dysbiosis in your stomach as low as possible. So if you're having belching or symptoms of gastritis or GERD, or you might want to contact me for coaching to try to help improve the microbiome of your stomach. Those are things that you would want to do. Make sure your vitamin D levels are good with your proper sunlight exposure.